The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name's Mark Ryan. It's a pleasure to be hosting the podcast, and thanks to everyone for listening in. We are going to stick with our Medicare Advantage topic here because in late November, the Centers for Medicare and Medicaid Services, or CMS, the outgoing Biden administration, issued a very large Medicare Advantage and Part D rule for 2026. I wrote a very lengthy blog about this on December 2nd at the blog tab of healthcarelabyrinth.com. That goes into greater detail than we'll be able to go into today. So if you want even more details after you listen to this podcast, go to the blog tab at healthcarelabyrinth.com and look for the December 2nd blog, and that will give you all of the details you really need. So we're going to take our normal 3 breaks today. This will probably be a little bit of a longer podcast because there's a lot to cover. So let's get right to it. So as I said, the Biden administration issued its draft 2026 Medicare Advantage and Part D rule in late November. A draft is available on the Federal Register site, which is where regulations are posted for comment and finalization. But the Federal Register indicates the rule was pulled back for additional clarifications and would be reposted on December 2nd. That said, we don't expect there to be a lot of differences between the unpublished version that we're looking at today and what is reposted on December 10th. I think it will just sort of be clarifications again. Due to the lateness in proposing the 2026 rule, the rule will not be able to be finalized by the Biden administration before the Trump administration takes office. And therefore, Trump will have a much easier time basically throwing certain parts of this out rather than having to go through a whole complex regulatory process of rescinding this rule if it was published and finalized in time. As you may remember, when Trump was leaving office back in late 20, early 21, he published rules early and finalized a lot of healthcare policy to sort of get a jump on what Biden would have tried to do, really sort of the polar opposite in many ways. And so the Biden administration came in and had a bit of a struggle to rescind some of the things they didn't like. But in this case, since this mega rule for 26 for MA and Part D is not going to be finalized in time, in fact, the comments aren't due until January 27th, Trump can basically ignore vast pieces of what's been proposed, except others which are just sort of doing day-to-day business of CMS and have a much easier time of taking out the things he doesn't like. So that's just a quick commentary. In some ways, the rule that the Biden administration has proposed does not have some of the mega changes that some expected in the areas of STAR, risk adjustment, and more. This could be in part due to some sensitivity to the current financial woes of the MA industry, but there is plenty for the industry to object to and probably will be thrown out by Trump. I have read again the 700-plus page draft rule and reviewed the Centers for Medicare and Medicaid Services fact sheet and the press release. And here, let's get right into it, are sort of the major things. Again, we'll take some breaks. We're going to break this up between Part D, Part C, and then general changes and STAR proposals, just sort of in that order. So let's start off with Part D first, the specifics of Part D changes. Well, one of the major bombshells in this 2026 proposed rule is coverage of anti-obesity medications and GLP-1 coverage. The biggest change in my view is clearly this in that rule, and it would cover weight loss drugs for obesity, including these very expensive GLP-1 drugs. The rule would reinterpret the current existing Part D statute to no longer exclude anti-obesity medications for the treatment of obesity from coverage under Medicare Part D, and to also require Medicaid programs to cover these medications when used to treat obesity. So today, the rule is interpreted to be available in Part D for those who are obese or overweight and also have qualifying disease states. So you can't get access to these very expensive GLP-1 drugs unless you have an underlying disease state and you're obese or overweight. The change proposed by the Biden administration would classify obesity as a disease state to enable coverage whether you have an underlying other disease state or not. Those who are only overweight would not be covered because that would not be classified as a disease state. Now, the big question for many is whether such drugs are mandatory to be covered in the rule. My reading is that while they talk about being permitted to be covered under the rule, that it is in fact a strict requirement. And if it's not an absolutely strict requirement, it certainly points in this direction based on my reading of the rule. The rule indicates that the drugs would have to be offered on the formulary and that prior authorization criteria would have to be pretty flexible in terms of initial and ongoing coverage. And we know that CMS has significantly loosened prior authorization in Medicare Advantage anyway. Whatever the facts may be on the long-term savings derived from covering such drugs, there is no question in my mind that including GLP-1 and related weight loss drugs in Part D will serve to further drive up premiums and costs in the short term. MA would be heard as a program, but the standalone Part D PDP program could be absolutely crippled. The administration is expected to make some GLP-1 subject to drug price negotiation. Now, we don't know where that's going to go with Trump, but that was the Biden administration's plan. But that alone, even if that does move forward, will not mitigate huge costs to the program. We know that price reductions in the negotiation process have not been terribly aggressive. And expanding Medicare coverage for GLP-1s likely will cost somewhere around $35 billion for Part D over 9 years. That's according to the Congressional Budget Office. CMS in the rule and in the press release and in the fact sheet ridiculously argues there would be no short-term impact on premiums in the Part D program. CMS and the CBO famously said the Inflation Reduction Act's Part D cost-sharing changes would not impact premiums either, and we know that was just simply not the case in 24 or in 25. So I think this is an area that Trump will probably look very closely at because, as we know, he's looking for savings for tax cuts. He can't afford a potential $35 billion price tag over 9 years in additional funding. So he likely will look strongly at pulling back on what the Biden administration wants to do on anti-obesity drugs. The next big issue under Part D in the rule is formulary inclusion in the placement of generics and biosimilars. So in an effort to stop pharmacy benefit managers from favoring brand drugs due to the rebate arrangements they have with brand drug makers, the proposed rule would require planned formularies to provide enrollees with broad access to generics, biosimilars, and other low-cost drugs. This will help with the uptake of biosimilars and likely help consumers at the point of sale, as brand rebates often do not get passed through in part or full at the drug counter. To implement this goal, the rule says CMS will expand its formulary evaluation process to do the following. First, assess whether the formulary includes generics, biosimilars, and other lower-cost drugs when available for brand drugs and reference products, and whether the generics, biosimilars, and other lower-cost drugs are placed on a lower formulary tier than the brand drugs or reference products. Second, assess whether a formulary incorporates fewer utilization controls on brand drugs and reference products than on lower-cost generic or other types of alternatives. Third, CMS will also use its authority to negotiate the terms and conditions of submitted Part D sponsors' bids if a plan's proposed formulary does not appear to provide broad access to generics, biosimilars, and other low-cost drugs. In addition, the rule indicates CMS is seeking comments in a number of different areas. Number one, the prevalence of manufacturer rebates and the extent to which such rebates influence formulary decisions that reduce Part D beneficiaries' access to generics, biosimilars, and other lower-cost drugs. And second, whether further programmatic actions within CMS's current statutory authority are necessary to prevent Part D formularies from excluding or disfavoring coverage of generics, biosimilars, and lower-cost drugs. So I actually, while I'm very suspicious of the anti-obesity proposal, I'm very supportive of this effort to really have uptake of biosimilars and penetration of generics and other low-cost drugs over brands. I think it's very, very important, and I think obviously Trump will endorse and continue with this proposal. The third area in Part D I'd like to talk about from the rule is pharmacy network changes. So the rule proposes a series of changes related to pharmacy networks. CMS is increasingly concerned about MA plan and pharmacy relationships, or PBM and pharmacy relationships, especially regarding inclusion in networks of independent pharmacies. So the rules changes would first require MA plans or first-tier downstream or related entities known as FDRs, such as PBMs, to notify network pharmacies which plans the pharmacies will be in a network for a given year by October 1st of the year prior to the coming plan year. It would also require MA plans to provide pharmacies a list of these plans to network pharmacies on request after October 1. This addresses one of the biggest complaints of pharmacies, that they're never quite sure what networks they're going to be in, and that can certainly impact the number of people that come in from that plan and things like that. Number two, the rule would also allow a pharmacy in a Part D network to terminate the contract with an MA plan or PBM without cause and with the same notice period if the MA plan or FDR has that right, an effort to sort of even the playing field. Right now, many PBMs and MA plans can just essentially, with very little notice, terminate a pharmacy. And essentially what this effort is again, leveling the playing field and allowing a pharmacy to have that same right if that right is in a contract in favor of an MA plan or a PBM. And last, third, it would require that pharmacies be enrolled in the Medicare drug price negotiation program's Medicare transaction facilitator data module. So just a quick technical reform there. With that, we have a little more Part D to cover, but we're going to take our first break right now, and we'll be back to conclude on Part D changes and then move on to Part C. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about the just proposed mega rule for 2026 by the Biden administration for Medicare Advantage and Part D. We're in the middle of talking about Part D changes in that rule. We're going to continue on with Part D before we get to some of the Part C changes here. So the next on our list for Part D rule changes are vaccine and insulin cost sharing. The rule proposes that the Medicare Part D deductible shall not apply to, and that there would be no cost sharing for any adult vaccine. There would be no deductible for insulin products either. In addition, the rule seeks to sort of codify in regulation some changes in the Inflation Reduction Act relating to Part D. And this rule would ensure that insulin costs will be capped at the lesser of $35 per month, or other calculations that could over time drive down the cost of insulin even below the current rate. So savings would accrue below $35 a month as well in the future. Next, we have the Part D Medication Therapy Management Program eligibility criteria. And what the rule is doing here is it would update the list of core chronic diseases used to identify Part D enrollees who have multiple chronic diseases for purposes of determining eligibility for the Medication Therapy Management Program and enrollment. The rule would add Alzheimer's disease as well as all other causes of dementia to the list of chronic diseases for possible enrollment. The change is again aimed at improving medication adherence and to reduce the risk of adverse events for people that have Alzheimer's and dementia. And last, in the Part D area, the rule has many, many pages on the implementation of the Medicare prescription payment plan. This also was passed as Part D changes in the Inflation Reduction Act in 2022. The rule implements the Medicare prescription payment plan, known as MP3, and codifies as in rule. The program essentially allows enrollees to smooth their cost sharing over 12 months and not face significant peaks in cost sharing early on in the year. I have been very critical of the program as administratively expensive, especially in light of the substantial reductions the IRA already put in place for cost sharing. It also can create significant risk for plans potentially. Again, the rule thoroughly implements the new IRA provisions. The text starts on page 40 of the unpublished rule and goes already all the way to 108. So there's a lot there in the unpublished version. It covers operational items, required outreach and education, enrollment, claims payment, and member rights, and much, much more. So let's move on to specific Part C changes here now as well. The first item in the Part C world is strengthening prior authorization and utilization management guardrails and further prior authorization reforms. So for 2024, CMS included via rule major restrictions on the prior authorization process for MA plans by requiring them to follow fee-for-service program policies. Now CMS is proposing further changes. CMS is proposing to define internal coverage criteria in the rule to clarify when MA plans can apply UM and prior auth criteria. They also want to establish policy guardrails to ensure access to benefits. They also want to ensure plan internal coverage policies are transparent and readily available to the public, and ensure plans are making enrollees aware of appeals rights. There's also some additional gathering of data and reporting to examine prior authorization processes as well. The rule also proposes to revise the required metrics for the annual health equity analysis of the use of prior authorization to require the metrics be reported by each item or service rather than aggregated for all items and services. So with that, we're going to take our second break here, and when we come back, we'll continue on with our coverage of Part C changes.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about the 2026 MA and Part D rule. We're in the middle of talking about some Part C changes in the rule. So next, we're moving on to clarifying MA organization determinations to enhance enrollee protections in inpatient settings. So, as a little bit of background here, hospitals and other providers that have facilities are constantly complaining that they receive prior authorization from MA plans, but when they submit services for payment, oftentimes those payments are denied or significantly delayed. So in the rule, CMS is trying to tackle a piece of this here. The rule would bar after-the-fact overturns of prior authorization that can negate claims payments. The rule states that if an MA plan approved an inpatient hospital admission, any additional clinical information obtained after the initial prior authorization cannot be used as new and material evidence to establish good cause for reopening the determination and essentially denying coverage and the claims payment. Next, the rule also is beginning to put in some guardrails for the use of artificial intelligence by MA plans and Part D plans. The rule would also increase guardrails on the use of artificial intelligence to protect access to health services. MA plans must provide all enrollees equitable access to services, including when an MA organization uses AI or other automated systems to aid in their decision-making. MA plans cannot discriminate on the basis of any factor that is related to the enrollee's health status. Next, we have some behavioral health benefit changes here. CMS is really focused on parity between behavioral and mental health in regular medical services. So the rule proposes a series of changes to ensure better access to mental health and substance abuse services. The rule would limit MA plan in-network cost sharing to what is charged in the traditional program. Supplemental benefits is also a big area of CMS focus and controversy. So here are some changes on supplemental benefits. CMS has already promoted some major reforms to ensure better utilization of supplemental benefits, including submission of such benefits and services via encounter data, as well as new education and outreach requirements. So it's adding these provisions in the proposed rule, introducing additional disclosure requirements to increase transparency, including additional disclosure rules around supplemental benefits and plan debit cards, specifying allowable and impermissible supplemental over-the-counter benefits, clarifying what types of over-the-counter products are acceptable, limiting marketing of supplemental benefits, including those surrounding the chronically ill, prohibiting MA organizations from marketing the dollar value of a supplemental benefit or the method by which a supplemental benefit is administered, requiring processes for delivering all MA plan-covered supplemental benefits to enrollees that ensure compliance with regulations, specifying the networks of providers from whom enrollees may obtain services for all benefits, but especially supplemental benefits, describing when, how, and in what manner debit cards can be used by an MA organization and enrollee, requiring plans to allow an enrollee to receive covered benefits through an alternative process if there is an issue with a planned debit card, and ensuring debit cards are electronically linked to plan-covered items and services through a real-time identification mechanism. Next on our list of Part C changes is promoting community-based services and enhancing transparency of in-home service contractors, another major point for CMS. Related to supplemental benefits, the rule aims to strengthen beneficiary protections and transparency around community-based organizations, in-home or at-home supplemental benefit providers in direct furnishing entities. These supplemental benefits are a little bit arcane, a little bit complex, and really not terribly well understood. And so that's why they're proposing this. The rule codifies definitions of these entities and requires plans to identify them within the provider directory. So we know more about the provider, more about the benefit, and they know that that benefit is being offered. And before our break, we'll take one more here, dual eligible simplification. The rule also seeks to simplify healthcare access for members of what is known as an applicable integrated special needs plan, an AIP SNP. These plans are the most integrated between Medicare and Medicaid. The rules would require integrated member identification cards that serve as the ID card for both the Medicare and Medicaid plan benefits in these plans. The MA plan would have to conduct an integrated health risk assessment for Medicare and Medicaid as well, not two separate ones. With that, we're going to take our last break now, and when we return, we'll talk about general programmatic changes in the proposed rule, as well as star proposals. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about the 2026 MA rule, and we are up to general programmatic changes and star proposals. So first on our agenda as we close the podcast out is medical loss ratio changes. Medicare Advantage medical loss ratio, or MLR regulations, will be changed to improve the meaningfulness and comparability of the MLR across MA plan contracts and align better with commercial and Medicaid requirements. The rule would require that provider incentive and bonus arrangements are tied to clinical or quality improvement standards in order to be included in the minimum MLR calculation allowance. Specifically, the rule would establish clinical and quality improvement standards for provider incentives and bonus arrangements to qualify for inclusion in the MA-MLR numerator. This would align such bonus payments with care outcomes and avoid excess premium transfer to providers. Administrative costs would be excluded from being included in quality improvement activities as well in both the MA and Part D MLR numerator. The rule would adopt additional requirements for the allocation of expenses in the MLR. New audit and appeals processes would be introduced as well. The rule would also require plans to provide detailed information regarding provider payment arrangements. CMS is also seeking information on potential policies that CMS could adopt regarding how the MA and Part D MLRs are calculated in order to enable policymakers to address concerns surrounding vertical integration in MA and Part D. Many of these provisions are a clear shot across the bow regarding intra-company arrangements between health plans and related entities to get around the minimum 85% MLR. The criticism is that intra-company deals between the MA plan and, for example, owned providers or owned pharmacies or owned PBMs are essentially passing down premium dollars that are not tied to true medical expense. And so these MLR changes are aiming to get around that. Again, very controversial, and we'll have to see what the Trump administration does with this provision when they review and finalize any 2026 rule. Next, we have marketing reforms to promote informed choice. So, surprisingly, CMS is not seeking to re-implement the court-overturned rule barring extraordinary compensation to brokers that essentially steer members to certain plans. To me, that was a great proposal. In some ways, I understand why it's not in this rule, because CMS would really need Congress to pass additional legislation in order for them to bar the extraordinary compensation. But again, I really feel like Congress and CMS should get together to do that, because steering enrollees to plans that are not in their best interest really has to stop. Nonetheless, here are some of the changes in the marketing front that this 26 rule does have. The rule expands marketing material oversight by broadening the definition of marketing so as to expand the scope of materials that must be prospectively submitted to CMS for review. CMS says this would allow the agency to better ensure that MA and Part D plans and their downstream entities are not providing misleading, inaccurate, or confusing information to current or potential enrollees, or engaging in activities that could misrepresent benefits or services. I'm all in favor with this change, but I'm still worried about those third-party marketing organizations that operate sort of on their own, even though plans should oversee them. Will those kind of ads really come into the scope here? I'm just not sure. The next reform in the rule is expanding what agents and brokers must discuss with potential enrollees. These new requirements include really two big areas. First, the availability of low-income supports, including the Part D low-income subsidy program and Medicare savings programs for beneficiaries enrolled into MA when first eligible for Medicare or dropping a Medigap plan to enroll in an MA plan for the first time. Brokers and agents would have to provide general information on Medigap federal guaranteed issue rights, the practical implications of switching from Medicare Advantage to traditional Medicare, and when applicable, provide information on state laws regarding Medigap guaranteed issue rights for those states where the agent or broker is licensed and appointed to sell. And the second area requires that agents pause to address remaining questions that the beneficiary may have related to enrollment in a plan prior to moving forward with an enrollment. Medigap education is a sore topic for opponents of MA who argue many are choosing MA, have a bad experience, and then cannot obtain Medigap when seeking to enroll in the traditional program. Just a small number of states have expansive guaranteed issue post an initial period of enrollment in Medicare. While I think opponents' arguments are overplayed, the change to me regarding education by brokers is nonetheless probably good policy. I know my friends in MA plans are objecting, but hey, I think it is actually a very good proposal by CMS. The last area before stars is formatting provider directories for the Medicare Plan Finder. CMS wants MA plans to essentially provide MA provider directory data so that it can be submitted for use to populate the Medicare plan finder and streamline some things there for CMS. I think a good proposal as well. Let's go on to STAR changes before we conclude the podcast. So, as you know, the STAR roadmap is constantly changing. The various annual rules as well as advanced notices essentially add measures, change measures, remove measures, and make technical changes. So keeping track of the STAR's roadmap is very complex and very hard. You really have to read a whole bunch of material because CMS really doesn't make it easy for MA plans because they don't really publish a really good roadmap. So CMS is proposing some significant changes in the future for the STAR program in MA and Part D. And here's just some quick summaries. On 12/5, there was a blog where I went into great detail about the STAR changes. So you can always go to the blog tab at healthcarelabyrinth.com, go to the December 5th blog on STAR changes in the rule to get more details. But here are the proposals really in summary. CMS is calling for inclusion of a Part C STAR measure called initiation and engagement of substance abuse disorder treatment. It's also calling for the inclusion of a Part D STAR measure called the initial opioid prescribing for long duration. It is expanding the population covered in the breast cancer screening measure in Part C. It is changing calculations, and the plan makes timely decisions about appeals in Part C. It's also changing certain calculations and the reviewing appeals decisions in Part C. It's clarifying how the Health Equity Index reward factor will be calculated when a contract consolidation applies, when there are data discrepancies or when data is missing. It's clarifying how the Health Equity Index reward will be calculated when dual eligible special needs plans offerings migrate from master contracts to freestanding contracts. It's clarifying how the health equity reward will be calculated for institutional special needs plan only contracts. It's clarifying how the hold harmless provision for highly rated plans is calculated in terms of the addition of the health equity index. And it's noticing all plans that the agency may finalize the permanent removal of guardrails that apply for non-CAPS measures from STAR cut point calculations based on a proposal in an earlier rule. Now, this guard rule change is pretty controversial. In the rule, CMS says it is considering finalizing its earlier proposal to remove guardrails for, again, the non-CAP survey measures when calculating cut points for measures. This would begin with measurement year 2026 or STAR year 2028. Guardrails are the bidirectional caps that restrict upward and downward movement of a measure's cut points for the current year's measure level STAR ratings compared to the prior year's measure threshold specific cut points. Generally, the guardrail is plus or minus 5 percentage points for each cut point, or a 5% difference up or down from the prior year on some measures. CMS argues that such guardrails are no longer needed with the implementation of the Tukey outer fence outlier deletions and the fact that extreme outliers are removed before the clustering algorithm is applied for applicable measures. This, the agency says, minimizes the need for guardrails to achieve predictability and stability of cut points. It argues the removal of guardrails would allow cut points to adjust when there are unanticipated changes in performance across the industry. I guess that could be up or down. CMS says it will address comments received regarding the removal of guardrails to the December 22 proposed rule in this final rule coming up. I am of two minds on removing guardrails. So let's talk about keeping the guardrail arguments first. CMS seems to argue that volatility will be less. We have not seen that of late, and an argument can be made that guardrails take out volatility overall. Number two, they can help some plans, and a lot is going on right now in STAR. As an example, some plans are protected by guardrails if they underperform others during this COVID recovery, and perhaps with newer measures after year one. Number three, there are a handful of measures that guardrails have delayed the significant impact of Tukey on cut points. For example, co-monitoring. CMS should keep the guardrails to allow plans to adjust to this impact that could still be significant, particularly on the lower end of performance levels. Now let's talk about getting rid of them arguments. Why should we get rid of guardrails? Number one, why shouldn't cut points be able to go up more than 5% if plans are performing better? Number two, guardrails also stop measures from dropping more than 5% when the market changes are resulting in lower performance across most plans. Sometimes that happens and plans would benefit. And third, at the very least, we need a modification to guardrails as the ECDS measures roll out via NCQA HEDIS. The first true ECDS measure, I don't really count breast cancer screening, to me is really colorectal cancer screening in STAR year 26. And we likely will see a major drop in scores because of the conversion to ECDS from manual chart reviews in this colorectal cancer screening measure. In my view, I would note, it also appears that the agency is again making a rule-writing mistake with regard to their proposal on guardrails. It has not included the guardrail proposal in the actual proposed regulation section and only references wanting to go back to this issue in the final rule in the commentary area of the publication. The commentary is not actual regulation. Simply referencing the earlier rule is not correct either, as the proposal then was not adopted in the final rule. I do not think the agency can now include elimination in the final 2026 rule, as it is not really proposed. CMS famously lost its guardrail application in the SCAN lawsuit over 2024 STAR ratings. With that, we'll conclude this episode of the Healthcare Labyrinth podcast. We know it was fairly long. Thanks for listening in, and we'll see you on the next Healthcare Labyrinth podcast. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.